Welcome to this explainer on gastrointestinal nutrition. If you're an internist, a hospitalist, or really any clinician managing GI patients, consider this your vital, modern update to the inpatient and outpatient dietary playbook. Okay, let's just dive right in. For decades, we've relied on deeply ingrained clinical habits when it comes to feeding the sick gut. But as we're going to see today, the evidence has evolved dramatically, and frankly, our everyday orders need to catch up.
Think back to your last shift on the wards. A patient comes in with an acute GI flare. Maybe it's pancreatitis, maybe severe gastroenteritis. Be honest, what's the very first thing you enter into the EMR? Is it NPO, nothing by mouth? For a long time, prolonged bowel rest was the undisputed gold standard that we all learned in training. We were taught that you have to starve the gut to heal the gut. But does that old NPO dogma actually hold up today?
Well, the short answer is no. In fact, current clinical guidelines are telling us the exact opposite. To put it bluntly, bowel rest is obsolete. Modern evidence firmly rejects prolonged NPO in favor of early, individualized refeeding. Instead of shutting the GI tract down, our goal is to safely and strategically keep it working.
Here's the agenda for today's explainer. We'll be looking at managing acute GI crises, chronic and autoimmune gut, functional and motility disorders, post-surgical dietary progression, and finally, the internist's final playbook.
All right, let's start with Section 1, Managing Acute GI Crises, specifically gastroenteritis, pancreatitis, and diverticulitis.
This perfectly illustrates the paradigm shift we're seeing. The old-school approach we're leaving behind relied heavily on the brat diet, bananas, rice, applesauce, and toast. We'd hold patients' NPO for 72 hours and then do those agonizingly slow ramps from clear liquids to full liquids and then finally to solids. But the new school? For acute gastroenteritis and even pancreatitis, the evidence supports resuming an age-appropriate regular diet early, often within 12 to 24 hours, and moving directly to soft solids.
Now here's a fantastic clinical pearl, particularly for pediatric gastroenteritis, the number 18. If you have a young patient with severe or prolonged infectious diarrhea, simply switching them to a lactose-free diet actually reduces the duration of their diarrhea by about 18 hours. You don't need a full gut rest period. You just need a smart strategic modification.
This one completely flips the script on acute pancreatitis. We all remember being taught to keep patients NPO until their pain resolves and their lipase normalizes, right? Well, those days are over. The new protocol? Initiate oral feeding early, within 24 hours, as long as bowel sounds are present and they aren't severely vomiting. You can actually skip the clear liquids entirely and jump straight to a low-fat, soft, or solid diet. If they can't tolerate oral intake by 72 hours, nasoenteric tube feeding is your preferred next step. We're reserving IV nutrition strictly for true ileus or obstruction.
And before we move on from acute crises, we absolutely have to bust a major diverticulitis myth. During an acute episode, yes, a clear liquid diet for the first few days is standard and helpful. But for post-recovery maintenance and prevention, there is absolutely zero evidence to support avoiding nuts, seeds, corn, or popcorn. None. In fact, a high-quality, high-fiber diet is exactly what they need. So you can finally tell your diverticulitis patients to go ahead and enjoy their popcorn.
Moving right along to Section 2, Chronic and Autoimmune Gut, focusing on inflammatory bowel disease and celiac disease.
For inflammatory bowel disease, diet isn't just an afterthought. It's a really powerful therapeutic tool. Take exclusive enteral nutrition, or EEN. This is a 100% liquid nutrition formula diet used to induce remission during active Crohn's disease flares. It's a non-pharmacologic intervention that is incredibly effective, with the absolute strongest evidence sitting right in our pediatric populations.
But IBD nutrition is really all about timing. During an active stricturing flare, you absolutely need a strict low-residue, low-fiber diet, modifying textures by blending, cooking, and advising very thorough chewing. But once that inflammation settles down and the patient is in remission, the goal completely shifts to reintroducing fresh fruits, vegetables, and soluble fiber. The ultimate target for IBD remission is actually a robust, nutrient-dense Mediterranean-style diet. Speaking of strict diets, let's quickly clarify gluten-related disorders. True celiac disease, yes, that requires a strict, lifelong gluten-free diet, and if your patient still has symptoms, you need to look for gluten contamination. It is the #1 culprit. However, non-celiac gluten sensitivity, or NCGS, is a totally different story. It's often transient.
Unlike true celiac disease, an NCGS diagnosis is not necessarily a lifelong sentence. Expert guidelines suggest you should actually rechallenge their tolerance after a 12 to 24-month trial.
Next up, Section 3, Functional and Motility Disorders, including IBS, GERD, and gastroparesis.
Take a look at this single digit, 5. That is the number needed to treat for the low FOMD diet, which restricts fermentable carbs and sugars in irritable bowel syndrome, particularly for the diarrhea-predominant subtype. An NNT of 5 is a massive clinical pearl. It basically proves that dietary intervention is the most evidence-based first-line therapy we currently have for IBS.
But here is where we as clinicians often get it wrong. Low FODMAP is not meant to be a permanent lifestyle. It's really a temporary 3-step progression. Step 1 is a strict restriction for about 6 to 8 weeks. Step 2 is a systematic reintroduction of specific food groups to identify triggers. And Step 3 is personalization, aiming for the least restrictive diet that still keeps their symptoms at bay. Ideally, you want this guided by a dietitian so your patients don't end up with long-term nutritional deficiencies.
When it comes to gastroparesis, you aren't just prescribing food, you are literally prescribing physics. It's a mechanical prescription. Patients need 4 to 6 small meals a day. You have to keep it low-fat, around 25 to 30% of daily calories, and low in non-digestible fiber. But here's the secret. Severe fiber restriction isn't entirely necessary if the food is properly homogenized to a tiny particle size of just 1 to 2 millimeters. And remember, gravity is your friend. Liquid-based meals are going to empty much more easily than solids.
Now let's see how this targeted approach works for our GERD patients. We all prescribe PPIs like it's second nature, but look at this emerging evidence. A structured dietary trigger elimination, cutting out individual triggers like caffeine, alcohol, spicy foods, or late-night meals, allowed nearly 45% of GERD patients in one review to stop their pharmacotherapy entirely. Diet alone resolved the need for medication in almost half of the patients.
Almost there. Let's look at Section 4, Post-Surgical Dietary Progression, covering bariatric and GI surgery pathways.
The ERAS pathways, enhanced recovery after surgery, strongly favor early postoperative oral intake, but it absolutely must be staged. A standard bariatric escalation looks like this: clear liquids on the day of surgery, full liquids on post-op day 1, continuing for about 10 to 14 days. Then you move to pureed foods around week 2, advancing to soft foods, and finally back to regular solids by 4 to 6 weeks. It's a strict, measured progression focused very heavily on hydration and protein intake.
Finally, let's bring it all together in Section 5, the Internists' final playbook, summarizing the acute versus maintenance phases.
If you take anything away from this explainer today, let it be this summary matrix. Seriously, screenshot this. It's your perfect cheat sheet for your next shift. Notice the journey from the acute phase to maintenance. For pancreatitis, early low-fat oral feeds instead of fasting, moving to a regular diet. IBD, low residue during a flare, stepping up to a Mediterranean diet for maintenance. Diverticulitis, clear liquids acutely, transitioning to a high-fiber diet with no need to ban those seeds. Gastroparesis, highly modified, homogenized small meals. The overarching theme here is crystal clear. Feed early, adapt the texture and macronutrients to the acute inflammation, and progress to a nutritionally complete diet as soon as humanly possible.
Which brings us to our final thought. The evidence has spoken, and the old dogmas of strict gut rest, they've been retired. So I want to leave you with this question for your next clinical rotation. If prolonged gut rest is clinically obsolete, how many of our patients are we unnecessarily starving simply out of habit? It's really time to aggressively evaluate our default NPO orders and start embracing modern, evidence-based feeding protocols. Thanks so much for joining me on this explainer, and I'll see you next time.